Thank you very much. And that PhD is, I can see the light at the end of the tunnel. It is possible for everybody to do that. We're getting there. We're getting there.
Yay.
But focusing this evening on congenital upper limb differences and the role of the midwife in this systematic examination of the newborn. And thank you very much for having us here this evening. So if you're a NIPE, newborn infant physical examination practitioner, or systematic examination of the newborn, and that takes it out of England, it takes it to all four countries, it's about realising what you should be able to do. So obviously we're looking at the eyes, heart, and the hips and the testes when we're doing those examinations. However, as a midwife, you're never just isolating yourself when you're doing examinations. You're looking wider than that, and that's why it's a systematic examination. And it requires extensive skills and knowledge of anatomy, physiology, of how to communicate the findings to the birthing family. When all appears normal, and that's most of the time, however, it's considering what to say and what to do when a difference is noticed as well. And in this session, we're going to focus on the examination of the upper limb as part of that systematic examination of the newborn. When we're teaching our students at Birmingham City University, particularly focusing down on examination of the limbs, we say that they need to apply their underlying anatomy and physiology of development of the musculoskeletal system. So these are the things that you need to know as a midwife if you're considering upper limb differences. You need to be able to recall the examination of the musculoskeletal system and be able to critically examine all the main anomalies of the musculoskeletal system. And importantly, apply those NIPE principles, those newborn infant physical examination principles, to the holistic approach to that examination. So just to put a little bit of context in here for us, where are our limb differences actually sitting in the grand scheme of things? So we can keep this in context a little bit. And this just presents some of our UK congenital anomaly statistics for us. And I think you can probably see my pointer there, but this covers all limb deficiencies or differences, not just our upper limb ones. But you can see this is a prevalence per 10,000 live births, and it's under 30. So we are looking at relatively small numbers, but that does mean that as midwives, we may not come across very many of these in our times as looking after mums and babies. So we really do have to think very carefully about how we approach these parents and how we approach our examinations, because we are probably not going to become very experienced in doing this as midwives examining babies on a day-to-day basis. So we need to rehearse how we approach parents, what we say to parents, and bear a few things in mind. And hopefully, as we go through the presentation, some of those things, the consideration for our practice will pop up. So we tend to do two main examinations as midwives in the UK. The first one is our initial examination of the newborn. So once the baby's just been birthed, whatever kind of birth the baby's had, we'll do an initial examination within the first few minutes into that first hour after birth. And it's really important that we observe carefully. We can miss things, so that observation shouldn't be taken lightly. The initial examination should involve a general observation, a good top to toe, and that obviously includes the upper limbs as well. But we should be looking at posture, the newborn's posture, symmetry of movement, symmetry of size, shape, alignment, and position, and the upper limbs will form part of that observation as well. I've got an example there of syndactyly. Now, there's a lot of complex words that come along with upper limb differences. This is just joined digits. And a very simple task that we do as midwives when a baby is born, we count fingers and toes. It might seem very, very simple, but it is incredibly important to actually take fingers and toes and go 1, 2, 3, 4, 5. And note if there's any fusion or any webbing, or that we do actually have 5 fingers on the thumb on each hand and 4 fingers, but 5 digits. I've known a case where a baby has managed to find its way home into the community before an extra digit was picked up on a hand. So that baby will have gone through an initial examination. It will have gone through its NIPE examination at 72 hours that we will get onto in a moment. And it was picked up by a community midwife who undertook her role, meeting the baby and family for the first time, and did a really thorough observation and examination of the baby in her own right. That baby really should have got home before we spotted something like that. That should have been picked up early, because that would leave the parents with all sorts of feelings about, well, why wasn't it, and so on. So don't overlook very, very simple things. And we know how busy it is out there, but we do need to do these examinations. And a lovely article that Ruth will probably refer to later, she's one of the authors on that article, notes that 57% of differences are noted in the postnatal period. So we're not necessarily picking up that there's going to be an upper difference in our babies antenatally. So as midwives, we need to be really vigilant, and we'll be providing care for a lot of these babies. We need to document if we do notice something, or we confirm that everything is normal. Documentation is key at birth. And if we do notice a difference, start that referral process early, because the earlier that parents are referred in and the baby is referred into a specialist system, the better, so that they can receive specialist care. We then move on that every baby will have a systematic examination of the newborn, or a NIPE examination within 72 hours, whether they're born at home, whether they're born in the hospital, or whichever location they're born at in the UK. This is a much more detailed examination of the newborn, and you have to undergo specialist training. But as Sue was commenting earlier, this is now a standard in the undergraduate curricula. So all our student midwives are being trained in the newborn and infant physical examination, systematic examination of the newborn. It's very important to note the history. So before you've even gone to speak to parents and have a look at the baby, you're having a good look at the history. Is there anything in the notes? Is there anything antenatally that has been picked up? Look for those risk factors. Is there anything in the associated history? Also talk to parents. So have they noticed, anything with their baby? Are they happy? Do they have any questions? However, if you do note there's a difference, or you suspect that there's a difference, you need to be very careful with how you phrase things, so parents don't think they're to blame for anything that may have happened with their baby. So how we couch our questions to parents needs a little bit of thinking about. Again, we're repeating that observation on our baby, exactly as you did with that initial examination of the newborn. We've got transferable skills as midwives, and we're going to do that general observation again, top to toe. How are our upper limbs moving in relation to the rest of the body? Posture, symmetry of movement, size, shape, and alignment and position. And any differences may range from something very simple, such as an accessory digit, to more complex presentations. It could be a one-off something, it could be part of a syndrome, and Ruth will pick up on those more complexities a little bit later on. The other things that we do as a midwife as part of the systematic examination of the newborn, we use palpation more so than we would do in the initial examination. And we're going to try and identify the presence of component parts. Have we actually got all the bones that we should have, starting with the clavicles, moving down through the humerus, radius, ulna, our fingers. Obviously, it's difficult to feel those individual bones. The hands are made up of multiple bones. But you'll see, is the baby moving? Have we got our grasp reflexes as well? Have we got our normal range of movement? Have we got asymmetry? We have to think about, well, if we have got asymmetry, well, what on earth does that mean? We don't want to alarm parents. So as a midwife, our role isn't to diagnose, and we'll get on to what our role is on the next slide. We need to think about, have we got loss of movement, and what might that actually mean? So, for example, a brachial plexus damage to the bundle of nerves coming through the neck down into the sort of into the shoulder slightly, then it could be, well, yes, I picked up something as a risk factor. This baby had a traumatic birth, there was a shoulder dystocia, those pictures of the jigsaw are coming together. But again, I'm not going to tell the parents that, because that's not my role as a midwife. But I could ask them, have you noticed anything with your baby? How's the baby moving? Are you concerned about anything? Very general questions, but no questions that are going to suggest that the parents have done anything to cause any problems with their baby. We're going to document, and specifically around the NIPE or the SEN, it's about documenting on S4N, so it's specific NIPE documentation. Baby's clinical notes, and that varies from hospital to hospital. Mostly these are electronic these days, but children still have, and babies still have, the red books. So those are carried around with them. So it's important everywhere that child is going to go, the documentation is clear. And we have NMC guidance, Nursing and Midwifery Council guidance in the UK, about how to document and our professional responsibilities around that. And things like the person and child health record is a joint form of documentation for multiple healthcare professionals, and it's important to have that joint information in there. At this point, we're going to be doing some referrals. So from the NIPE point of view, we should have local arrangements in place, and for any other arrangements as well, that if we pick up any other differences, including our upper limb differences, you need to make sure you're at your own hospitals that you do have referral pathways in place. And if you don't know, if it's the first time you've come across something, because it isn't something that's common to you, then you need to ask. There's absolutely nothing wrong with asking if you are unsure. And luckily in Birmingham, for example, we're very lucky to have a big children's hospital. So our local hospitals within Birmingham have a ready resource on tap for them for upper limb differences. And that will get referred to a little bit later on. I think it's also important that as midwives, we maintain our training and our competency as well, because we may train in, year are we in now, 2024, but if we don't practice those skills, we might become a little bit rusty, and you might need to do some CPD. You might need to have a refresher over those skills. You might need to go on study days about differences that you're not familiar with. So it's about your professional knowledge and maintaining that. And only you know what you know. So you need to think about your own CPD and decide in your sphere of practice what is good for you, so that you are competent. The next few slides I'll just go through very, very quickly, but some examples, although many of them are very, very rare, because we know that the numbers of upper limb deficiencies, differences rather, is small, but they can have a long-lasting impact on parents if we don't get that initial communication right. So here you can see, for example, humerus. Is it the right length? Is it actually there? Hands, size, shape, posture, inflection. Have we got all the digits? Have we got nails on there? And our reflexes, which I mentioned a moment ago. We should check our baby's reflexes. Are they symmetrical? If not, question, why not? Some more very, very rare instances of upper limb differences here as well, which you can have a little look at. So separation of the clavicles in there, shoulder dislocation, very rare, but if you've had a very traumatic birth, it may be something that you see. And whilst that can be solved and treated, there's other conditions that will need much longer management. And our brachial plexus injuries, we mentioned these briefly a moment ago. So you may see some of these, a Klump's palsy, Erb's palsy, and your reflexes won't be very good, or rather the baby's reflexes won't be so good. So if, as a healthcare professional, as a midwife, you notice an upper limb difference and you seek advice about what to do about this, at some point you're going to have to talk to the parents. You can't hide this. It's originally on the left-hand side there, it talks about breaking bad news, but on the right-hand side, I thought, No, I don't want to say breaking bad news, because actually you're just breaking different news. Perhaps parents will expect you to say, "Oh yeah, lovely, lovely, that's great, off you go home." And you're actually going to impart some different news to that and set them off on a different journey that they perhaps weren't expecting. But if you're going to give somebody, you could call it bad news, you could call it different news that they weren't expecting. We need to think about how we actually do that, because if we get this wrong, this is something that can stay with families for an awfully long time. And this is where, as midwives, we can actually make a big difference. So there is a model called the spike model. It was developed in oncology. It's a good model when we need to tell somebody something, and we just need to consider about how we tell them. And we're not going to give them a diagnosis. We're just going to tell somebody that we've noted a difference here and we need to do something about it. So we need to think about the setup. We need to think about what we want to say in advance. So if we've got some idea that we're going to come across a difference already, we can plan this in our head. However, if you're the person, you're the midwife that's just noticed something, a bit less planning, but we can think about it from now onwards in case we come across anything. You might want to suggest that the mom birthing family have their significant others there, or a friend or a relative. Maybe they want to call someone in to be with them, and whilst you have that discussion. Time and sitting down with somebody. So that is really, really important. Time is always a problem in midwifery. We don't have time to do anything. However, we have to make the time for this. To sit on a bed next to somebody, to sit on a chair next to somebody, and just hold their hand, offer some comfort, is incredibly important. So we have to set up that information giving, importantly. Perception. Before I tell somebody that I've just noticed that your baby has X, Y, or Z, I need to ask them, have you noticed anything about your baby that you're worried about? Have you noticed anything, over the last few days, or, since your baby's been born? Open-ended questions. What do you understand about this? So you're giving the birthing families chance to actually ask, but also a chance to tell you that, oh yeah, I did notice that, and I was going to ask you about that. It gives them that sense of control that we're on the same page here. You've noticed it, I've noticed it. Let's have a conversation about it. But also checking that they're ready to hear this and that they're receptive to some information, or actually, maybe we need to come back later. We also then need to actually give that information. What would you like to know? Different people want to know different amounts of information. Sometimes we can't take all that information in at once, and we might need to stage that. Little bit of information now, come back later. And also that level of information, it's good to know who you're talking to, but even if you've got somebody who you deem to be, it's a healthcare professional, they're not being a healthcare professional at that moment. They're being a mummy and a daddy, or a birthing family. And the emotions will take over. We need some knowledge, but also it's about imparting some knowledge to the parents as well, using non-technical language, but gentle language, but not patronizing language. Is important. Small bites of information. Do we have some written information to back up what we're saying? So if we're delivering difficult news, it might go in one ear and out the other. Can't remember, I was upset, I was crying, or I was stunned by what you've just told me. If we can have written information to back up what we're saying, that's important. And then we've got emotions as well. We need to consider the birthing family's emotions. Do they need time alone? Do they not want to be alone? Where do they want to be with their baby? Do they want to be around all these other babies that they may deem as normal, or they might not want to have a side rib? It's about working out what that family wants and not what I think they should be having. So you have to have a dialogue there. But it's also about thinking about us as midwives and our emotions as well, because if we haven't encountered this particular difference before, we might need to talk it through as well. But predominantly, this is about the birthing family's emotions. And the emotions will go on. The support that's required is continuous. And this is going to lead into Ruth's presentation. So emotional support and empathy is required as per the Spike model. Reassurance and support is important, and that will mean that we have to hand over that information. So to health visitors, community midwives, and make sure there's a smooth transition and the next step of support is in place for these parents and baby. Honesty is absolutely important. But we do need some knowledge. So if we're thinking at the moment, oh gosh, I really don't know what all those words were a minute, I don't know anything about upper limb differences, then now's the time to think, right, okay, let me think about that and learn something extra about it. Referral is essential. So again, if we don't have those referral pathways, that's something we need to go back to our organisations and think about, what will we do if we have a baby with an upper limb difference? And support groups, they are absolutely essential, because once parents go home and the baby goes home, there can be a lag in time before they get to meet the appropriate healthcare professional who's going to take them the next part of their care journey. And there are some fantastic support groups out there. Reach is one of them that Ruth is going to go on and talk about. But for example, just at Birmingham Women's Hospital, Women's and Children's Hospital, we've got our Children's Hospital just down the road. There are activities for children and families. They do a hand camp, for example, which I think is linked to Reach when I was talking to Ruth. And it's just to normalise things. These children are children fundamentally, and they might have a difference, but it really does not stop them. And we mustn't stop them as healthcare professionals. A whole load of useful resources there. So when you are recapping this, then you can have a look at those references. And I know Sue has a whole lot of references for you as well. And that brings you to the end of my short presentation there, and I shall hand you over. Thank you very much.
That's lovely.